Okay, our second speaker is Dr. Petchara Sundarathiri. Currently, Dr. Petchara is head of anesthesia unit in the Priyatai 1 hospital in Bangkok. She is one of the founder of the regional anesthesia 6 years ago, and he's an honorable instructor of the Ramati Bodhi Hospital and instructor in the postgraduate diploma of the RA in Analgesia in Dubai. Currently, she is a chair scientific committee of the Thai Society of Regional Anesthesia, and she was first president of the Thai Society of Regional Anesthesia since 2012. Her research interest is about neuralgia and peripheral nerve block, acute post-op pain management, ambulatory anesthesia, and ultrasound-guided regional anesthesia and interventional pain management. Let's welcome Dr. Petchara.
Thank you. Good morning, everybody. I'm going to share with you my experience where I have been done in regional anesthesia for total knee replacement. I think very few surgery will produce the post-operative pain as tri-compartment total knee arthroplasty, because before they have create your new knee, they have to cut your bone. No? Like reconstruction the house, they need to remove the bone and put the prosthesis. Okay. So in addition to the surgical insult, it's associated with stress response, and more than that, they expect the patient to get out of bed right away as possible. That is cause more pain. To achieve or have your functional outcome according to the rehabilitation program that the patient needs to follow according to your center, it cause more pain during rehabilitation. So over the last decade, more and more, this kind of surgery become very common. Even 90 years old patients, they are asking for TKA. And the surgeon done very well, right? They are safe. They can see the old patients came from the hospital after surgery, go to abroad because they can walk, they can regain function. How about us? We know that this kind of surgery causes severe pain. So it's our job to ease that pain and let them cooperate with the rehabilitation program safely and more comfortable. So the use of regional anesthesia and peripheral nerve block has facilitated and improved this goal. If we contrast when we compare with post-operative pain, when we provide the patient with IV-PCA, it's big different, because when the patient push the pump, he will sleep. He cannot get out of bed. If we compare with the hospital stay, it's even more longer, right? Especially with the old patients. And we find that if we put the block on the specific site or we do regional anesthesia, they have very few adverse events and the patient more appreciate according to less pain. I think there are a lot of literature review about this, but if we look at the post-operative pain organization, we still found that the fact is 70% of patients report moderate to extreme post-operative pain. What does it mean? It means in the worldwide practice, they're still doing IV PCA morphine. How about your center? You still doing that for TKA, post-operative pain? How many percent? Can you share with me? How about in this center? Who are here? Nobody here? Okay. So we need to do some prospect that we need to narrow angle and focus to solve the problem. So today we are going to talk about TKA, not ACL, okay, to procedure specific for postoperative pain management. How about the evidence base? So you need to look and read it. Managed and developed by anesthesiologists and surgeons. So it's our job, surgeon and us. How to achieve? We look the evidence base. We have to ask the patients what do they want from surgery or after surgery, what do the surgeon want and what do anesthesiologists want. The level of evidence, like in Oxford Center for Evidence-Based Medicine. But all of the evidence have limitation that you need to understand. Some limitation, like poor power, less than ideal design, or only one center, not the real world, okay? And some, they get the average pain score. It means 2.2 is come from 1 to 5 VAS. So we need to understand, and now and then when you read the new literature, you have seen enhanced recovery. What does it mean? Push the patient out of the hospital, okay, as soon as possible. So how about the patient? What do they want? Dr. Macario do the questionnaire. They give the 30 different questions to the patient and let the patient rate. And this is the overall ranking of the importance of addressing question. The most important for the patient, they are, will surgery cause pain afterwards? Is there anything I can do to eliminate pain after surgery? Or will I receive medication to manage the pain? So even the patient or us, we're concerned about severe pain. How about the surgeon? They do biopsychosocial approach to the patient, maintain muscle power. So when you do surgery, they check the patient right away that the surgeon can move the legs, the ankle or not. And active patient involve education, they follow clinical pathway and try to let the patient get out of bed as soon as possible to avoid DVT and to achieve the good physiotherapy. How about us? It's our job, good quality analgesia with minimal side effect. That's why we are interested to do regional anesthesia. For TKA, we do neuraxial block, we do peripheral nerve block. We may have to maintain skill or develop more skill, provide good surgical field, and optimize patient outcome. In my center before, I think 10 years ago, we do more on epidural anesthesia for TKA. Because regional anesthesia have variable outcome effect. Usually our patients are old, have comorbidity. We don't prefer to do GA. And within that time, 10 years ago, we love to do epidural anesthesia because we can put the catheter in. We can provide a good analgesia for our patient. So all of this may be all of the regional anesthesia technique that you can provide for TKA. Okay, spinal anesthesia, you may put spinal with spinal morphine, epidural, lumbar plexus, femoral, sciatic, adductor canal. And in combination with opioid, NSAID, or paracetamol. For the neuraxial, Roger performed a meta-analysis, compare neuraxial and GA. They found that postoperative morbid and mortality is lower. Of course, because we are dealing with the old patient. So the neuraxial block reduced the major postoperative complication like DVT, pulmonary emboli, blood transfusion, and pneumonia. Sharrock report a decrease in mortality rate from 0.36% to 0.01% when they conclude all of the incident of TKA and hip replacement. It's a good number. So for the epidural, what I have said, we can offer the extension of anesthesia, we can offer the postoperative analgesia very well and decrease the rate of DVT. Finally, in that time, I use epidural as the routine. But nowadays, the patient receiving anticoagulant, sometimes for the high-risk patient, after surgery, the next day they receive anticoagulant. So I have to take off my epidural. So my postoperative plan is broken. So we direct the focus from epidural to peripheral nerve block. For those who have to take the anticoagulant, so peripheral nerve block may be the good alternative. Okay, more than that, because it can provide unilateral analgesia. During that time, we focus on femoral nerve blocks. In TKA, when you're going to block for TKA, you need to understand that the nerve innervation, you need to block the femoral, obturator, and sciatic. There are three terminal nerve are target for this technique. And they have many studies about peripheral nerve block compared with epidural analgesia for major knee surgery. And they have demonstrated that they have comparable analgesia and improvement in side effect profile associated with peripheral nerve block. They find when you do peripheral nerve block, the patient have lesser side effects like dizziness, hypotension, urinary retention, and itching. So when I read that, I also interested to do, so I conducted my study. But what I have told you that the knee have three terminal blunts. Do we need to block femoral in combination with sciatic or not? Allen et al. Reported that additional sciatic nerve block to femoral nerve block for postoperative analgesia following TKA has been shown not to improve significant additional analgesic effect. Maybe he can provide a potent oral analgesic or systemic opioid in combination with femoral nerve block. So the analgesic efficacy or the effective may be more or less not big different. And the physical therapy also, for those who want to ask the patient to get out of bed on the day of surgery, should not do sciatic. The patient cannot walk. Okay? So I conduct the study to compare epidural with the femoral nerve block because I want to cheap the practice in Thailand. Because I told you that during that time we always do epidural. So I want to cheap the epidural to femoral nerve block, so I conduct this kind of study. And I found out that because when you do epidural, you can have very effective block, right? Because it's neuraxial. It's cover everything femoral, sciatic, or obturator. The patient had pain-free. But if we conduct femoral nerve block, the patient spare about the posterior part of the knee. And in my center, some of the doctor, the surgeon, orthopedic, they don't like to prescribe NSAID as routine. If the patient has contraindication, we skip the NSAID. So the NSAID is not the fixed protocol in my center. I found that the VAS score at postoperative 6 to 12 hours was clearer in femoral nerve block. What does it mean? The sciatic part, the posterior part of the patient, the posterior part of the knee, right, is spare in this group of the patient. During this time period, why not start from the post-op 1 to 6 hours? Because postoperative 1 to 6 hours is covered with the spinal analgesia. Okay, that's why the pain is shown after 6 hours until 12 hours post-operative. And I found that the side effect of the epidural, that's why that is the disadvantage of the epidural group. The patient, when they go to the ward, they sit and have meal. They find dizzy and vomit, according to maybe orthostatic hypotension or low blood pressure, according to the sympathectomy effect. For the rehabilitation index and duration of hospital stay are comparable in both groups. For me, I satisfy. This is the rehabilitation program in my hospital. The day of surgery, the patient lie on bed. For the first post-operative day, the patient may expected to be able to sit at the bedside and stand with help. On the second day, they can stand without help and use walker and transfer to chair with help. For the third day, the transfer to chair and walker mobilization without help was expected and discharged. So on the third post-operative day, the patient can discharge for home. And we also prescribe the oral medication for them. Of course, paracetamol, of course, NSAID, if they don't have contraindication. In some centers, they have even oxycodone. In Thailand, we don't have oxycodone. We have only tramadol or antacid. Some they add gabapentin. But in my hospital, we don't do it routinely. So there is some literature still said unsatisfied analgesia for TKA after femoral nerve block alone. But they also don't want to have sciatic in combination. I have been talking with Dr. Shinichi Sakura. He said sometimes he also does sciatic. Can we make it better? In my center too, we don't do sciatic because our orthopedic don't like. Because the patient cannot move the ankle. They are scared of nerve injury. So we do only femoral. But I still keep thinking, can we do it better? So I designed another study. I put the small dose of morphine intrathecal, that is mini dose of morphine, only 0.35 of morphine, very, very small. I do randomized study and I did the pilot before. I started from 0.07 milligram of morphine intrathecal. My patient vomit. I lowered down to 0.05 and finally I found that 0.035 is very optimal. It's very, very small, but it can ease the pain during the time period that I found in the first study. So the aim of this present study was just to find the benefit of additional midi-dose spinal morphine, 0.035 milligram, to continuous femoral nerve block for post-operative pain and compare their associated side effect. And the result is, in post-operative 12 to 24 hours, the VAS score was lesser in mini-dose spinal morphine group. And the rescue tramadol requirement also lesser in this group. The post-operative nausea vomiting was greater only in the short period of time, post-operative 0 to 6 hours. So I conclude that a mini dose of intrathecal morphine in addition to continuous femoral nerve block was found to be simple, safe, inexpensive, and more effective than we don't add mini dose intrathecal morphine. So now I don't care to do sciatic because I can't get any better, just only put small dose of intrathecal morphine. So I'm happy now. After I'm happy, another story comes. Adductor canal block, right? The recent studies that in femoral, when you put the catheter of the patient and the patient walk, the patient fall. In my center, we have one incident. The patient fell. According to we always keep telling the patient that after we took off the femoral catheter, you need to walk with walker. But some of the patients, he have very confident that we are strong. He's strong. He can walk by himself. He fell in the toilet. So the incident of fail. So we find another way around. We put the catheter in perineural catheter site. Distal to the femoral triangle is the adductor canal to avoid the motor block. Because the adductor canal consistently enclosed with staphylos nerve and the nerve to the vetus middleis. If you place the catheter in this canal, you can spare the major motor branch of the femoral nerve while providing effective pain relief. But the pain relief, I think the efficiency of the adductor canal block may be more or less lesser than femoral nerve block. Dr. Sundarathiri found that the infusion in adductor canal continuous peripheral nerve block for the patient undergoing TKA is associated with, in the incident, increase the total ambulation distance. He can walk longer, more distance if we compare with femoral nerve block alone, okay? But in my center, I told you that on the day of surgery, the patient don't walk. So I don't care to do this kind of block, except we encourage my resident or my young colleague to put the catheter. For the single shot adductor canal block, the duration of analgesia is not very short. It's not serve the purpose of post-operative pain for TKA. But if you're gonna do, you better put the catheter in. I think it's better. It's what I told you nowadays, they are encourage you to enhance recovery pathway. So to do the fast track, it means rapid recovery and accelerated rehabilitation, promote the patient to be active, to mobilize the patient out of bed, and you have to provide the effective perioperative analgesia. So the surgeon do local, right? To do the local anesthetic infiltration in the knee by himself. They mix the large volume of local with NSAID, sometimes with opioid and adrenaline. Some doctors, they infuse the local anesthetic. Some, they also maintain the catheter in the knee. And they found out that the patient can walk right away on the day of surgery. So they put the high volume of local anesthetic like 0.2% ropivacaine 300 milligram with the opioid or adrenaline. Most studies observe there is the reduction in early postoperative pain and opioid use, reduce the length of stay in the hospital without an increased risk of complication. But the number of questions still remain unclear. What are the questions for this technique? Single dose or continuous infusion? Some surgeons put the single dose, some patients put the catheter. There are now many of the study compared about this single dose or continuous infusion. They put the use of high volume infiltration combined with intra-articular infusion or further bolus dose, but not all studies have consistent results. Bush observed good outcome Canal observed not good outcome. So this is the area of study now. If you want to conduct your study, you may try to follow through this. And what is the optimal infiltration site? Is still be questioned. Dr. Anderson observed no difference between the use of intracapsular catheter or intra-articular catheter in TKA. But I think for this kind of technique, maybe it's good for the TKA that don't have put the drain. In my center, the surgeons still keep the drain in. So they will infill local anesthetic only for the single injection. They don't put the catheter in. For the RCT placebo control, they said the subcutaneous wound infiltration provided a reduction in both static and dynamic pain score at 24 hours. Okay, they still have benefit. If we compare local anesthetic infiltration with continuous epidural, some of the study, they still have a better quality of analgesia and early mobilization in the local anesthetic infiltration group. And they found that epidural, you need skill to do, you need time to do, and you need care, more care to do too, if compared with local anesthetic infiltration. If they compare local anesthetic infiltration with peripheral nerve block, even they have very little publication compare about this, but they still have a positive outcome when they do intra-articular infiltration. But Dr. Kali observed the femoral nerve block is the most effective. So there is still controversy. If it's do so, we lost the job. Because the surgeon done surgery and conduct the pain control. You are nothing now. So fortunately, I found the review article. The review article, the procedure-specific systematic review and consensus recommendation for post-operative analgesia following TKA. The evidence support. You can do GA if your patient have no comorbidity and combine with femoral nerve block for surgery for post-operative analgesia. Or you may do spinal with spinal morphine as alternative. And when the patient is at ward, don't forget to put the cooling and compression technique. It's also effective analgesia, very effective. In my center, they have cooling by pulling the cool water in the back to the knee. It's very effective. And you have to give them the good analgesic, of course. If the patient has severe pain, you need to think about the strong opioid. Some centers, they have oxycodone, methadone, but in my place, we don't have. I have only weak opioid for moderate to low intensity pain. For the intra-articular technique of local anesthetic or morphine are not recommended. So they cannot do their job. Okay? Because the inconsistent analgesic efficiency in procedure-specific and transferable evidence. Because the consistency of the result is not homogeneous. Some they are good, some they are not. And those who put the NSAID, neostigmine, clonidine, and corticosteroid are not recommended too. If they combine the intra-articular with incisional technique after the completion of this review, several randomized controls have been performed with the high volume local anesthetic in both TKA and hip replacement. There still is the preliminary evidence is promising, but the technique requires further evaluation before the current recommendations are revised. So they are still following through conduct some study now. For the combination of femoral and sciatic, a combination of femoral or obturator block cannot be recommended because of limited and inconsistent procedure-specific evidence. For the adjuvant, like clonidine or epinephrine, also are not recommended. For the central neuraxial technique, spinal clonidine is not recommended.
Sorry,
For-
Dr. Petchara, you have 2 more
Okay.
minutes.
Epidural, okay, is the long time ago of practice, right? Now, what are the good evidence to support the spinal injection and morphine? And you may do the cooling and compression. According to they need to enhance the recovery. They don't support to do femoral much. They may do spinal morphine in combination with the cooling, compression, and good analgesic. So my conclusion is a great deal of research is currently underway to determine the optimal analgesia for all types of surgery. Since the pain experience is specific to the individual, not all patients will nearly fit into predefined post-op pain categories. However, the major knee surgery can be expected to generate high level of pain or severe pain. Therefore, I base my recommendation on the evidence presented here with the caveat with every analgesic regimen should be personalized to the individual patient needs and your rehabilitation program. Thank you for your attention.